we will see about history and the physical examination of neonates and the classification of newborn. Neonatal history taking, physical examination of newborns and the classification of newborn. Let's start from neonatal history taking. Neonatal history taking starts from asking maternal profile, such as age of the mother, occupation, and also parity of the mother, blood group and RH status of the mother, any chronic medical maternal illness such as diabetes, hypertension, retroviral infection, renal disease, history of sexually transmitted disease such as syphilis, hepatitis B virus, and also HIV. Ask for symptoms like vaginal discharge, genital ulcers, or investigations like VDRL, PICT, and hepatitis B virus that was done during antenatal care. The other is current pregnancy. When was the last normal menstrual period? The first day of the last normal menstrual period. And calculate the gestational age from this last normal menstrual period. Antenatal care, how many visits the mother have antenatal care and what was done during the antenatal care. Any bleeding, any history of diabetes, medical illness such as thyroid, eclampsia, any acute or chronic maternal illness. And also ask about previous pregnancies, any history of abortion, any fetal days, early neonatal days, history of premature or low birth weight baby, history of early neonatal jaundice during the previous delivery, history of birth defect, and also drug history of alcohol ingestion, cigarette smoking, any medication during pregnancy, especially anticonvulsant, anti-TB, anticoagulant, thyroid treatment, and also drugs such as cotrimoxazole, aspirin, albendazole during pregnancy. Family size, marital status, housing conditions, water source, waste disposal, and the personal hygiene should be also documented. Then the next is about labor and the delivery, onset of labor, status of rupture of membrane in relation to onset of labor, whether the rupture of membrane is before or after onset of labor, duration of rupture of membranes, duration of labor, mode of delivery, presence of meconium stained amniotic fluid, fetal presentation, Apgar score at delivery, breathing condition at birth, whether the baby cried immediately after birth or not, any resuscitation done at birth, and also documented birth weight. Then next we will ask the presenting complaint. The complaint that brought the neonate to neonatal intensive care unit. Failure to suck, or it might be fever, it might be breathing difficulty, abnormal body movement, yellowish discoloration of the skin, or it can be vomiting, bleeding, or birth defect. The next is physical examination of newborn. Unlike adult, the order of newborn physical examination might not follow the usual cardinal steps. You should have to use the opportunities. Look for movement of the extremities, muscle tone, color, posture, and the respiratory distress. And do Ballard score and estimate the gestational age. And also document vital signs and anthropometry. Normally, the normal heart rate at birth is in the neonatal period is around 120 to 160. Normal respiratory rate for neonates is between 30 to 60. Normal body temperature is between 36.5 to 37.5 for maxilla. The length is 50 plus or minus 2. And head circumference is 35 plus or minus 3. And the weight is, the average is 3.25, but the normal birth weight is between 2.5 to 3.99 kg. The next is head and the neck examination. We should have to examine the fontanelles, the size and the tension, and also sutures. And we should have to check the presence of caput succedanum, which is due to scalp edema that crosses the midline. We should have to also check for cephalohematoma and subgaleal hemorrhage. Cephalohematoma does not cross the midline and it's caused by subperiosteal bleeding, whereas subgaleal hemorrhage is a bleeding in the potential space between the skull periosteum and the scalp gallia aponeurosis. This crosses the midline and it causes extensive bleeding. The next is examination of the face, nose, eyes, and the ears. We should have to check for the presence of cleft lip and the cleft palate, high-arched palate, any dysmorphic facial features, shape of the nose, nasal flaring, and the choanal atresia. To discuss them specifically, we should have to examine the shape of the nose. The newborn baby's nose often appears compressed, particularly if there has been reduced amniotic fluid. This will correct spontaneously in few days. Nasal flaring is when the nostrils widen as the baby breathes. This is a sign of respiratory distress and needs urgent assessment. Choanal atresia should be suspected when there is respiratory difficulty, which is relieved by crying. As during the crying, babies breathe through their mouth rather than their nostril. And the respiratory distress worsens when the baby breastfeeds. So, a respiratory difficulty which is relieved by crying and worsened by breastfeeding is high likely choanal atresia. In choanal atresia, the nasal airway is narrowed or blocked by a bony or membranous septum across the posterior nasopharynx, and in most cases, or two-thirds are unilateral. When choanal atresia is bilateral, it is an emergency, and the infant rapidly becomes cyanosed. The emergency test for choanal atresia is try to pass a number 6 catheter 3 cm down to the nostril. If we can't, it is choanal atresia. The other is about examination of the eye. We should have to check for the presence of ptosis, large eye discharge, and red reflex. Large eye is indicative of congenital glaucoma and is usually associated with corneal edema. Red reflex should be elicited for both eyes to exclude the presence of congenital cataract. An absent red reflex is a sign of congenital cataract, while a white red reflex could indicate retinoblastoma. The other is examination of the ears. Check for low-set ears. Ears are considered to be low-set when the root of the helix is on the level below a horizontal line drawn from the corner of the orbit. Check also pre-auricular skin lesion. Lesion on the face anterior to the ear. They may be fleshy papules or tags or superficial dimples. Some consist of skin only, others contain some cartilage. They are encountered in 1% of babies, and renal ultrasonographic examination is not recommended unless there are other anomalies. Macrotia is a disorder where the external ear is underdeveloped. The macrotia ear is smaller in size, and the external auditory canal is absent in most cases. Macrotia is encountered in a number of syndromes such as Tricher, Collins, and a hearing deficit will be present if there is macrotia. The other is about examination of neck. Observe the appearance of the neck, whether the neck is short or not, whether there is redundant skin in the neck, and also presence of mass and range of movement. If there is congenital neck mass, try to classify as preauricular, postauricular, midline, and lateral neck, because each have their own differentials. For example, preauricular mass is due to lymphatic malformation or hemangioma, whereas postauricular is due to fist brachial cleft anomalies, and midline can be due to thyroglossal duct cyst, ectopic thyroid, dermoid cyst, lymphovascular malformation. Lateral neck, congenital neck mass might be due to brachial cleft anomaly, lymphovascular malformation, thymic cyst, sternocleidomastoid tumor infancy, laryngocele. The other is about chest. Enlargement of breast might be a normal finding due to hormonal withdrawing, and the chest of the newborn normally is barrel-shaped and smooth at birth and expands symmetrically. Occasionally, irregularities in respiratory rate with apnea up to 10 seconds can be normal. This is breathing pattern of newborn. It's not apnea. If it is irregularity of breathing, of cessation of breathing up to 10 seconds without any color change. When we came to heart and the blood vessel, maximal cardiac impulse is felt in the left fourth intercostal spur. Murmurs are present in large number of normal newborn, but the lack of murmur does not eliminate the diagnosis of congenital heart disease. When we came to the abdomen,
The liver's age usually is felt 1 to 2 centimeters below the costal margin in the neonates. And the umbilical cord contains two arteries, which are small and thick walled, and one vein, which is larger and thin walled. Umbilical hernia is a common finding in newborn, and we should have to also check for abdominal wall defect, such as omphalocele and gastroschisis. Omphalocele is abdominal visceral herniating into the base of umbilicus, which is covered by membrane, and most of the time omphalocele is syndromic, and gastroschisis is intestine outside the body through the abdominal wall defect without any membrane covering, and most of the time gastroschisis is not syndromic. When we came to genitalia, the baby should urinate within 24 hours. Testes normally are in the scrotum of term infantis, and the newborn penis is greater than 2 cm length. A mucoid vaginal discharge is present in nearly all mature female infantis due to hormone withdrawal. Mild scrotal hydrocele is common normal finding in newborn male babies. We should have to also check for anal area and the anal patency. Normal newborn should defecate within 24 hours. Also check for the skin of the newborn. The skin might be covered by a white, greasy, easily removable material called vernix cages. Mongolian spots over the back are a normal finding, and there are also other benign neonatal skin problems such as pustular melanosis, milia, erythema toxicum, and others. When we came to the neurologic examination of newborn, check whether the baby is alert or not, and also check for neonatal reflex. From the neonatal reflex, Moro reflex is one. Moro reflex is obtained by placing an infant in a semi-upright position. The head is momentarily allowed to fall backward with immediate re-support by examiner's hand. The child will symmetrically abduct and extend the arms, fingers opening, followed by flexion and adduction of the arms, which is an embracement-like action. It can also be produced by loud noise or sudden motion. This Moro reflex appears at birth and disappears at 4 months of age. An asymmetric response or unilateral absence might signify a fractured clavicle, brachial plexus injury, or hemiparesis, whereas a bilateral absent monoreflex shows significant dysfunction of the CNS. Persistence of monoreflex beyond 4 months shows cortical brain damage. There are also other neonatal reflexes that the baby born with to help them survive, such as grasp reflex, crawling reflex, palmar grasp reflex, rooting reflex, suckling reflex, and placing reflex. The last thing that I wanted to talk about is there are a lot of physiological phenomena of the newborn that we should not worry about. Those are physiological weight loss up to 5 to 10% of the body weight during the first 5 to 10 days of life, overriding or molding of the bones of cranial vault, vernix caries, acrocyanosis, physiologic jaundice, benign neonatal skin problems such as lanugo hair, Mongolian spot, milia, erythema toxicum, bluish sclera, mucoid vaginal discharge, which might be tinged with bleed, breast engorgement, periodic breathing, and jitterness. Those are physiologic phenomena, so you should not worry about those things.
The third part is classification of the newborn. Newborn can be classified based on gestational age. A newborn can be classified into preterm if it is less than 37 completed weeks, term if it is between 37 to 42, and postterm if it is more than 42. Gestational age could be estimated by one of the following methods: on the basis of the first day of the last menstrual period, or on ultrasound estimation. Gestational age estimated during the first trimester in ultrasound can be accurate within 5 to 7 days, and it can be estimated at birth based on Ballard score at birth. Ballard has two components: neuromuscular and physical maturity scoring, and the accuracy is within range of plus or minus 2 weeks. The second classification is classification of newborn based on birth weight. Normal weight is between 2.5 to 3.99. We call it macrosomia if birth weight is above 4. Low birth weight is between 1,500 to 2.499 grams. And the very low birth weight is between 1,000 to 1,499. Extremely low birth weight is just less than 1,000 grams. The third classification is classification with respect to birth weight and the gestational age. We call it appropriate for gestational age if the birth weight is between 10 to 19 for that gestational age, and large for gestational ages if birth weight is greater than 19 percentile, and small for gestational ages if birth weight is less than 10%. This is all about neonatal history taking, physical examination, and the classification. Thank you for watching and also for subscribing.